Bismillah ar-Rahman ar-Rahim. Today I'm going to present this lecture which I did last year for Pakistan Society of Neurology regarding nervous system involvement in COVID-19. As there is a vaccine in the market, so I believe there are more updates and more education to acquire to guide our patients better. So I'll start with the hadith from Holy Prophet, peace be upon him. When you hear that a plague is in a land, do not go to it, and if it occurs in a land that you are already in, then do not leave it, flee from it. And it very much applies to our current condition as we are facing this pandemic for more than 1 year now. As we all know, COVID-19 is pretty much similar to our regular influenza virus and share many characteristics, including it's an RNA virus. It does mutate, as we have noticed in the past 1 year, but the mechanism of involvement of the peripheral nervous system and central nervous system kind of varies. So there could be direct nerve injury, as it has been seen with the olfactory nerve involvement or taste involvement, and in rest of the body. There could be immune-related injury with respect to cytokine release, as it has been noticed with muscle injury. Also, with respect to our central nervous system blood-brain barrier disruption and injury related to that, causing many different varied manifestations. Additionally, there could be molecular mimicry, and it could be similar to what we see in Guillain-Barré syndrome with ganglioside and other protein involvement and immune reaction related to those proteins. So the neurological complications and manifestations of COVID-19 kind of varies from central to the peripheral nervous system, but it pretty much involves all of the nervous axis. So in central nervous system, there could be dizziness, headache. If a patient already have history of headaches, like in migraine, there could be worsening of migraines. Acute cerebrovascular disease or stroke, encephalopathy or impaired consciousness. There could be immune-mediated transverse myelitis, acute hemorrhagic necrotizing encephalopathy, encephalitis, epilepsy, ataxia. In the peripheral nervous system, predominantly what we have seen is hypogeusia, which is reduction in sense of smell, hypoosmia, neuralgia or pain syndromes, Guillain-Barré syndrome, and skeletal muscle injury. In the past 1 year or so, I have seen a good number of patients with COVID-related worsening of primary pain syndrome, either it's fibromyalgia, migraine, or else. The epidemiology of neurological disorders includes that it involved the 36 to 57% of the cases mentioned some kind of neurological manifestations. And severe the viral infection is, as it goes with the respiratory moment, more gonna be the neurological manifestations in these patients. The stroke and vascular events, according to a nice paper by Dr. Adnan Qureshi, it is around 1.3%. The polyneuropathy or peripheral nervous system involvement is up to 8.9% in these cases. And there could be muscle injury additionally. The high-risk neuromuscular cases are the ones with hereditary neuromuscular conditions, acquired immune-mediated conditions, respiratory muscle involvement, cardiac and bulbar involvement, and comorbid systemic conditions like diabetes mellitus. So if a neuromuscular patient has respiratory or bulbar involvement or cardiac involvement, they are prone to develop severe COVID infection. So the factor increasing risk of severe disease, as we just discussed, is underlying use of immunotherapy or multiple immunosuppressive agents. If they are on high-end immunosuppressive therapy, talking about monoclonal antibodies or stronger chemotherapy medications, there is additionally swallowing or breathing muscle involvement, and the patient has baseline cardiac disease or diabetes mellitus, or liver disease, or pregnancy, all these systemic factors put these patients at risk of having the severe COVID infection. The potential neuromuscular complications directly by the COVID-19 infection could be, as we just discussed, with the molecular mimicry, there could be Guillain-Barré syndrome. With direct muscle injury, there could be myositis. And if a patient end up in ICU, there could be critical illness myopathy or polyneuropathy. There is risk of exacerbation of the primary neuromuscular condition, or unmasking of neuromuscular condition means patient doesn't have overt disease and it becomes overt deterioration. And it could range from the nerve to muscle to neuromuscular junction. And then naturally going to be risk of immunosuppressive immunotherapy, because these patients are prone to have more severe disease. Naturally, they're going to be increased risk and severity of infection in these patients. Additionally, there have been multiple medications tried in COVID infection since last 1 year. There is chloroquine, hydroxychloroquine, and azithromycin has been used pretty commonly. But these medications can worsen baseline neuromuscular condition or neuromuscular disorders. So a physician suggesting or a pulmonologist suggesting these medications should be very careful when they are ordering these medications, because there could be potential worsening and patient may end up in ICU, and there could be devastating consequences in that case. Next, there are risks of the vaccine, which I'm going to discuss during my talk. When it comes to the nerve involvement, there could be cranial, mono, or polyneuropathy. As we just discussed, the most common ones are the olfactory nerve, which has been seen in 39 to 88% of the cases. There could be facial or taste involvement in 36 to 60% of cases, and there could be Miller-Fisher syndrome, and there are some reported cases for that. But the more common one is because of the direct involvement or direct injury to the olfactory or the taste sensation. There could be polyneuropathy. Again, there are some cases or few case reports over the period of the last 1.5 years of Guillain-Barré syndrome, critical illness neuropathy, or iatrogenic sensory polyneuropathy secondary to medications. Myopathy, or the myalgia, has been very commonly seen in these patients. It can be worsening of the baseline condition, and it can actually last way longer even after the patient has recovered from the COVID infection, to the point that even if the CK level is done and that is normal, still the patient continues to complain about muscle fatigue and muscle cramps. So fatigue can be in 44 to 70% of the cases. There could be high CK level in 33% of the cases. There are increased chances of rhabdomyolysis in patients who are having baseline metabolic myopathies. Additionally, there could be toxic myopathy because of medication and critical illness myopathy if the patient ends up in ICU. Neuromuscular disorders, there could be exacerbation of the primary disease. There could be hypoxic respiratory failure. As we all know, the patients with neuromuscular junction disorders like myasthenia gravis, they tend to have repeated infections more commonly than a regular population of the same age. But it actually didn't end up all the time in hypoxic respiratory failure. But because of the COVID infection, they are prone to develop hypoxic respiratory failure. Intravenous immunoglobulin can be used in patients without complication, despite there was initial concern that IVIG can promote thrombotic events, as it has been noticed with some vaccines. But so far, the data is scarce, and IVIG would be a preferable treatment in patients who are noticing neuromuscular deterioration. There has been a case series where they mentioned the use of monoclonal antibody, tocilizumab, in complicated refractory myasthenia gravis who presented with exacerbation and not improving, and it was helpful to wean the patient from ventilator. But we should avoid medication which can worsen the baseline condition, like azithromycin and hydroxychloroquine should be avoided as much as possible. So general points regarding neuromuscular condition that they should continue on their current treatment, whatever it is. It's steroids, it's immunosuppressive therapy, So their baseline condition is not worsened and they're not ending up in hospital where there are going to be more chances of contracting COVID infection. If needed in these patients, then stress dose steroids can be given, especially in cases of muscular dystrophy. So stress dose steroids can boost their response and can help recovery of COVID infection, as well as let them come out of the acute phase of their neuromuscular condition. If they are unable to take oral steroids, then IV medications can be done or hydrocortisone intramuscularly can be used. But we should try to bring these patients to hospital as much as possible, and home infusions should be arranged to avoid infection. These patients should not be given any neuromuscular blockage medications because they're going to be more worsening and they may end up in ICU and on ventilator. There was initial concern because this patient shares the receptors with angiotensin converting enzyme inhibitors and ARBs. So there was concern that these patients should not be used these medications because it can worsen the condition. Like patients who are muscular dystrophy patients, and because of their cardiac involvement, they are continued on ACE inhibitors. These patients can be continued on ACE inhibitors because so far, again, the data is not enough to suggest that these medications should be stopped, or they're going to be worsening to the point that they become critical. There are increased chances of infection, as we just discussed, in neuromuscular disorders compared to normal population, and with immunosuppressant, the chances of infection increases by 19% even more. As we all know from our previous knowledge that in CIDP cases, there is antecedent infection and vaccination in 12% and 1.5% cases respectively. So with molecular mimicry with the COVID vaccine, we should expect kind of similar response in our patients who contracted the COVID infection. So around 1.5, somewhat more or less of these patients can develop CIDP or Guillain-Barré syndrome. There could be peripheral nervous system involvement in COVID cases up to 8.9%. In patients who are on immunosuppressive therapy, continue immunosuppression as outpatient. In case they develop COVID infection, we can temporarily stop immunosuppression or reduce the dose, or switch to less immunosuppressant medication after discussion with the patient. So the safer approach in neuromuscular cases is to do intravenous immunoglobulin or plasma exchange in case of acute deterioration, or if they end up in ICU or emergency department. Complement inhibitor therapy has been safer compared to monoclonal antibodies and other medications, and we should try to do home-based therapy as much as possible. So this is just a chart of what we have discussed so far. So the patients who are on symptomatic therapy, there shouldn't be any change in dose, and the medications are mentioned in the list. If the patient is on immunomodulatory therapy like edaravone, nusinersen, patisiran, we should consider home-based infusion to avoid exposure to infection, but otherwise there is no need to change the medication. If the patient is on IVIG, plasma exchange, complement factor medications, again, home infusion should be arranged to avoid risk of infection. But if the patient is on corticosteroids, consider using a low dose or stress dose in case patient develops COVID infection. If the patient is on immunosuppressive therapy, talking about mycophenolate mofetil, tacrolimus, methotrexate, these medications can be stopped temporarily or reduced dose can be tried in the period of time, so they may not contract severe disease. If the patient is on immunomodulating high-end therapy like rituximab, ocrelizumab, cyclophosphamide, we should, if they are first time being tried on this medication, then we can postpone infusion for a safe period of time if possible. If they are already on maintenance treatment, we should try to reduce the dose and try to reduce the amount of medication if possible. If not, they should be continued on it and they should get the vaccine whenever feasible. And we should use ancillary services more judiciously to avoid the risk of infection. So the current statistics as of today, the global COVID cases are 166 million, and there has been a total deaths of 3.45 million. In Pakistan, the COVID positive cases are 0.9 million, and the reported deaths are close to 20,000. The reported critical cases at this time are close to 4,400. So in the list of nations, Pakistan is at the position of 29 in terms of number of cases. But if we look at the population size, Pakistan is number 5 in the population or most populated countries. So these are very optimistic numbers. And I think the government and population of people have tried some good measures to avoid contracting infection. And I think they should continue to do that. But we should also remember this part. It is just like flu. So just as in flu infection, you get flu vaccine every year to avoid severe flu infection. We may need to continue taking COVID vaccine probably every year to avoid getting severe COVID infection, because this virus has already mutated and there are certain variants in population noted. And in the passage of time, there may be more variants and they may be more severe. So we need to continue getting the vaccine in future as well. So there are certain responsibilities of physicians and patients. If a patient notices any new symptoms or worsening of the pre-existing disease, they should let their primary neurologist or primary physician know about that, because that will help us gather more data and guide our future patients. If there are thrombocytopenia or thromboembolism stroke, they should be educated beforehand so they can recognize those symptoms, because these symptoms have been noted with COVID infection and in response to vaccination. If there are any symptoms, the patient should seek medical advice. And in that case, we should get the thrombotic profile to know if they are thrombotic prone. Do we need to do anything in terms of anticoagulation? And there should be a detailed report sent to NCOC and DRIP to guide further treatment in our high-risk population. So coming to the high-risk group, females who are pregnant or who are using oral contraceptive pills, naturally they are on the immunosuppression side, and there are chances of getting the severe disease, and they may get severe infection. Patients who are having heparin-induced thrombocytopenia or thrombotic events in the past, they tend to develop thrombotic events in the future, and they should be guided about stroke and what to look for in case of thrombotic event. If the patient is immunocompromised, either it's because of the medication, like we discussed in our neuromuscular patient population, cancer, or HIV, they are prone to develop severe infection. Also, they may not get an optimal response to vaccination. And because there are multiple vaccines available, getting the antibody titer may not be very helpful. So these patients need to be guided accordingly and should get vaccinated as soon as possible. So the current vaccines available in the Pakistan are inactivated whole virus vaccine and viral vector vaccine. The difference between the two is in inactivated whole virus vaccine, there could be more severe systemic infection. And these patients can develop more side effects of the vaccine. The current available vaccines are Sinopharm and Sinovac. In response to the viral vector synthetic vaccine, there has been reports of thrombotic events, especially with respect to AstraZeneca. So we should be careful when we are guiding our patients. And patients who are thrombosis prone, they should not get viral vector vaccine. They should rather get the whole virus vaccine. But on the other hand, patients who are on immunosuppressive therapy or who are immunocompromised, they should get the synthetic vaccine and they should not get the inactivated live virus vaccine. So the live vaccine can cause more severe systemic infection. The vaccine should be given 4 weeks before rituximab or immunosuppressive therapy to get an optimal response to the vaccine. And there are influenza-related GBS within 3 weeks of vaccine, so it's kind of similar phenomena in COVID-related worsening, and risk of serious influenza outweighs the risk of GBS. So in patients who have GBS, they can still get the vaccine, okay, and it's going to be a similar risk. But they should report if after getting the vaccine, they develop new onset neuropathy or nerve weakness. Same brand vaccine should be used for the first and the booster shots. Don't administer vaccine for 2 weeks after another vaccine. So if you have already received vaccine for some other reason, like flu vaccine, yellow fever vaccine, you should not get COVID vaccine for at least 2 weeks. Autoimmune disorder patients should get vaccine unless contraindicated. But I think the preferable course would be getting the not the live, but the synthetic vaccine. In case of pregnant patients, it's even more tricky, and it should be discussed with them, and informed decision should be made about getting the vaccine or not. So in summary, entire neuroaxis can be involved in COVID-19, and symptomatic non-immunosuppressive therapy can be used. In case of immunosuppressive therapies, can be spaced or delayed if possible. Live inactivated vaccines should be avoided in immunocompromised cases, and synthetic vaccines should be avoided in thrombosis-prone cases. Common sense prevails in addressing issues when there are no clear guidelines, and data over time will clear the issue around immunosuppression and vaccination. Thank you very much. I really hope that this lecture will help my physician colleagues, especially in the realm of our domain of neurology, neuromuscular medicine, and general physicians as well, to guide their patients so they can have less side effects or less complications. In case there are still issues, please refer your patients to more higher specialists who can guide them better. Thank you very much. Have a good day. Assalamu alaikum.